This is a 15-minute webcast for GPs and other health professionals. It features excerpts from a series of talks given by cancer specialists to GPs in Tower Hamlets in 2011. The talks coincided with the launch of the Small C Public Awareness Campaign. The aim of these talks, and the Small C campaign, is to improve the early diagnosis of cancer. This talk is about prostate cancer. It's the first of 3 on this topic. It gives an overview and looks at diagnosis and lasts for 14 minutes. Part 2 is about symptoms and issues following diagnosis. Part 3 is about staging and treatment. The speaker is Jamur Patti, Consultant Urological Surgeon at Barts Health NHS Trust and Homerton University Hospital NHS Foundation Trust.
We have in the UK about 37,000 patients diagnosed every year. That's every day 101 patients, which means every 15 minutes one patient is diagnosed with prostate cancer. Although the incidence of prostate cancer seems to be on the definite rise, the mortality rates haven't really changed over the last 10 years, and that would suggest perhaps that our treatment of it or our diagnosis of it is not effective. So still perhaps we're diagnosing people too late. So this is another message that, maybe we need to get on the bandwagon like the Americans did and start treating it more aggressively. So the risk factors are basically age. We know that with increasing age, the risk of prostate cancer increases. And in patients who are, say, under 50, there's hardly any patients, and you'll know that from your own practice. We have 1 or 2 coming through just after 45, but there's usually some other risk factors related to their incidence of prostate cancer. By and large, they will be over 50, predominantly actually around the 70 age group. Now that could be that we've not diagnosed them early enough, so maybe we should be looking at 50-year-olds and being more aggressive in diagnosing or looking for their PSA rises, and that way maybe we'll find younger patients with localized disease who we can then treat more effectively. With regard to race, Afro-Caribbean men will know from this area particularly we have a huge incidence of prostate cancer, and particularly in areas around Newham, Hackney, that we tend to have a large number of not only prostate cancers, but when we actually biopsy these patients, we find that the higher volume of cores are positive with disease, and the higher number of cores are more positive with disease. So they have a larger disease burden, and they have a more aggressive type of prostate cancer. They also sometimes present much earlier as well. Geographical distribution in the areas around Southeast Asia, very, very low incidence of prostate cancer, and much higher incidence of prostate cancer in North America and Northern Europe. So that has some impact on it. However, if a Japanese gentleman went off to the United States and decided to immigrate there, their tendency to get prostate cancer is increased. So there's obviously some other factors apart from the geographical distribution. And one of them is, of course, diet. And we know that a high intake of fatty foods, animal fats in particular, are involved in lots of different cancers, and prostate cancer is one of them. Other than that, a low amount of vitamins, isoflavonoids, those kind of sort of fruits, vegetables contain these things. A lower intake of that seems to impact negatively on cancer, particularly prostate cancer. So genetics is another definite factor for risks in lots of different cancers, but again in prostate cancer. If one first-degree relative has prostate cancer, then this patient has a 2-fold chance of developing prostate cancer. If 2 family members, first-degree relatives, have prostate cancer, that increases to 5 times as high. So definitely there's an impact. So if there were 9 men in this room, then one of those 9 men would develop prostate cancer. A 50-year-old man with a 25, so who's going to live to about 75, he would have a 42% chance of having microscopic prostate cancer, which may or may not be clinically significant, but a 9% chance of developing a clinically significant prostate cancer, and a 3% chance of dying of prostate cancer. Now, in the past, we found out about prostate cancer mostly because patients were having TURPs, transurethral resections of their prostate, just because they had bladder outflow obstruction or were in retention. And then histologically, when the tissue was examined, we would find some of the tissue had prostate cancer. So that's why the diagnosis, this is pre-1989, was mainly due to surgery that was thought to be for benign disease, and incidentally, cancer was found in some of the histological specimens. However, after 1989, with the emergence of the test PSA, which is an assay that we do to measure the prostate-specific antigen in the patient's blood, we found a larger number of, and increasing awareness about the PSA increases the diagnosis or a guesstimate that this patient may have a diagnosis of prostate cancer. And this is how many patients will come to you just where you've done an incidental PSA test for some other problem. Often they have lower urinary tract symptoms, they may have some bone pains and aches. Sometimes just in the elderly population, you just do it as a routine screener. And then we'll be contacted because this patient's PSA is above the normal limit. However, as you all know, prostate-specific antigen is also produced by normal prostate, and therefore it is prostate-specific but not cancer-specific. So even while the PSA was developing, there were lots of different things that we were looking at. PSA velocity, how fast it would go up, PSA density, how many units of tissue was producing the PSA. So larger prostates produced more PSA, and therefore a higher range could still be benign. So we were looking at all the different ways of how we could say that the PSA would more effectively look at which patients should be biopsied. For at the moment, we get a raised PSA patient, we often have to biopsy them if they don't have any other symptoms of, say, urinary retention, or they don't have a symptom of prostatitis, urinary tract infections. Those would we would pull them out of the equation and say, we'll just watch your PSA for a little while, maybe give you some antibiotics, maybe wait until after the trauma of the acute retention episode has settled. But aside from those patients, most of the patients, we have to biopsy them when their PSA goes up. Digital rectal examination, obviously the more we do, the better we are at it. So where you might only be doing, 3 or 4 in a week, maybe, I don't know. Is that do you do often more? Less even, you were saying. So if you were doing less than that, then the chances of you actually having an educated finger to examine that prostate is difficult. Because you're not going to have the volume of patients coming through. So what we can then do is any patients who we feel are suspected of having prostate cancer, we can then go on to do a definitive test, which is the transrectal ultrasound-guided prostate biopsies. Basically, the patient is turned onto a left lateral position, and a probe is inserted into the back passage, and just in front of the rectum is the main bulk of the prostate. Now, as you know, the prostate is sort of a conical in shape, like a ring donut with the urethra running through it at a slight angle. So it comes down like that and then goes through it at a slight angle. So with the bulk of the prostate will be behind the urethra and just in front of the rectum. So when we do transrectal guided ultrasound, we can take the bulk of the prostate and take biopsies from various areas. However, we do miss a small area in the anterior zone, which can lodge cancer. And for that, we often do what we call template biopsies. So for the normal biopsies that we take, they're usually done under local anesthetic, and the patient is in and out. It's not even a day case procedure, it's more an outpatient procedure. They're there for maybe half an hour, and then they wait outside just to check that they're okay, and then they're allowed home with usually some kind of prophylactic antibiotics to take. Now, by and large, we divide the prostate up into 3 zones on each lobe, so that's 6 zones, and we take 2 biopsies from each, so that'll be a total of 12 biopsies that we take. And we can then say right mid, left mid, right. And when you get letters from us, you might notice that there's these kind of allocations as to which biopsy was positive. So the sextant biopsy is by and large the main type of biopsy that we do. When patients have a rising PSA after their initial biopsy, which has come back as negative or benign, then if their PSA, which is being monitored, goes up again, or we're not happy and it's persistently raised, then we may decide to do what we call extended biopsies. Now, just to be kinder, the extended biopsies are done under general anaesthetic usually, because the patient will request for it to be done under general anaesthetic. And instead of taking 2 cores from each of those 6 areas, we take 3 cores. So now we have 18 pieces of tissue to examine. So those 2 having been done, if this patient now continues to have a raised PSA, then we will arrange for template biopsies. And the area that we're targeting in the template biopsy is the anterior zone of the prostate, which we might have missed when we were doing the transrectal ultrasound-guided biopsies. And so these template biopsies are pretty radical. I mean, it's almost like having a radical prostatectomy, because you do nearly sometimes up to 50. There's a grid, and you can take up to 50 sort of different samples from different areas serially along the whole of that prostate. But also it will target areas from the anterior zone. So there are some new diagnostic tools, because you can see that the diagnostic tools that we have at the moment, the DRE, the TRUS, and the PSA, isn't really very sensitive. All together, collectively, until we actually get tissue that tells us that someone's got prostate cancer, then only. But even if we have a diagnosis of prostate cancer, we really don't know, is this the type of prostate cancer that is going to be clinically a problem for this patient? Or have we picked up the 42% that are only going to have microscopic disease? This is really what we want to know. Because in the past, we all know that we've been taught, and even medical school certainly, that people mostly die with prostate cancer and not of prostate cancer. So really what we want to find out is, who are the patients who are going to be troubled with a clinically significant prostate cancer, and who are the patients that are actually at risk of dying of an aggressive type of prostate cancer? So there's a laboratory in London called Bostwick Laboratories that have devised this ProstaVision test. It's a genetic-based test where they can look at 3 different genes and look to see if these genes are present, it is more cancer-specific rather than prostate-specific. Well, prostatitis is often something that we pick up as a result. So the biopsy result will say there was no evidence of cancer, but there is chronic prostatitis or acute prostatitis. So they don't usually get prostatitis due to the biopsy, but they may often have prostatitis that then comes to light. And then you treat the prostatitis with perhaps an alpha blocker to reduce any obstruction, and then also perhaps an antibiotic, which may then, calm down the inflammatory markers. And then eventually the PSA may start to come down. So it will give us a guide as to maybe, even though they don't have cancer, maybe they have something else which is also treatable to bring down that PSA. Erectile dysfunction after biopsy is, I've not heard of it per se, but there may be some anxiety-related issues of being diagnosed with prostate cancer that may impact psychologically on the patient, that may not, immediately make them want to have sex. But, so I think that aspect of it has to be borne in mind. But generally speaking, the biopsies may result in sepsis or urinary tract infection, hematuria, so blood in the urine, hematospermia, and rectal bleeding. And very, very rarely, if they have large varices in the rectal area that may not be picked up when they're having their ultrasound scan, because it will look at the prostate, it doesn't necessarily look at the mucosa of the rectum. If a needle goes through one of these varices, it's very, very rare. The patient doesn't feel any pain or anything, but of course they do have a bleed, significant bleed afterwards. And very, very rare though this is, when that happens, the patient can lose significant amount of blood. I mean, we've had to transfuse somebody about 10 units at one point because they had, a varices that then, it did settle, but it's just something that is to be borne in mind, that these procedures are not without their risks. But the majority of patients will actually not have a problem. It can also bring about an incidence of exacerbation in urinary symptoms or acute retention. So those are the main things. But top of the list is sepsis.
That concludes this webcast on prostate cancer. This is part of a series of 10 webcasts available at this address. The Small C campaign aims to improve cancer survival through better public awareness and early diagnosis in East London. You can find out more at this address. And you will find more useful information on these websites.